on the next couple minutes. I just want to thank everyone again for joining us for the Frontiers in Child Health Research Seminar. The seminar is held on the second and fourth Mondays from September through June. And their series includes speakers with work focused on child health from UCSF, as well as guest speakers. Please let me know via email if you're interested in speaking or would like to suggest a speaker. Looking ahead, our next speaker on November 27th is Dr. Marissa Raymond-Flesch from the Division of Adolescent and Young Adult Medicine. We are still virtual and using Zoom, so we ask that you stay muted unless you have a question, and we'll also open it up at the end to questions. Today, we're welcoming Dr. Fernando Gonzalez, Professor of Pediatrics in the Division of Neonatology and the Director of the Neonatal Intensive Care Nursery. Fernando also serves in the department as the Director of the Pediatric Residency Molecular Medicine Track and for the Society of Pediatric Research as the co-leader of Pediatrician-Scientist development. His own funded research has been supported by NINDS, and he has had multiple collaborations with laboratory, translational, and clinical investigators, including the NIH-funded multi-center randomized high-dose erythropoietin for asphyxia and encephalopathy, or HEAL trial. His research focuses on determining how the full-term brain responds to acute injury during the neonatal period, investigating strategies to enhance protective and regenerative responses and long-term functional outcomes using basic science, translational, and clinical research approaches. The title of his talk today is Neonatal Neurocritical Care, Past, Present, and Future.
All right, thank you kindly for that introduction. Let me start this. Can you see the slides?
Yes.
Okay, sounds good. Okay, I'm gonna get started. So thank you also for the opportunity to speak today. I will discuss the concept of neurocritical care in the newborn, really focusing on 4 key concepts: how we identify newborns with potential brain injury, how we can protect the brain or prevent injury from happening, how can we potentially prepare the brain after early injury, and really strategies to optimize long-term neurodevelopmental outcomes in all the patients that come through the intensive care nursery. And this will include a discussion of emerging research at UCSF and controversies in the care of these neonates and how we plan to address those in the future. And one of the main goals for this talk is really to make it clear to everyone that all critically ill newborns are at risk for brain injury and long-term neurodevelopmental disability. I will be talking about a number of different things: prenatal risk factors, premature brain injury, full-term brain injury, as well as short and long-term outcomes. And so I'm going to be bouncing back and forth a little bit, depending on what the topic is. And so I have this graphic here that's going to appear on some of these slides, where I'm going to highlight which age group that I'm referring to help keep track. So first, I'm going to start by defining neurocritical care. So this refers to a distinct multidisciplinary subspecialty that's focused on the comprehensive management of neurological problems. Now, in adult medicine, these units have evolved first initially for post-op care of neurosurgical patients, then broadened to deal with other neurological diseases such as stroke, seizures, traumatic brain injury, and now they include a number of monitoring and imaging interventions to provide brain-focused care for these patients, but also to provide time-sensitive interventions and neuroprotective strategies. And so evidence shows that providing this specialized neurocritical care in these units improves outcome for these patients. Once again, this is in the adult population. It reduces morbidity and mortality, and it improves resource utilization. Also, importantly, it provides care to help reduce or prevent secondary brain injury. So focusing on basic physiology and monitoring to provide the best supportive care. And using this protocol or guideline-driven approach provides higher rates of favorable outcomes. And so this table on the right, this shows improved survival in patients who present with an intracerebral hemorrhage in a neurocritical care unit here on top compared to general intensive care unit below. So that's in adults, and this has been part of adult care for quite a long time. But what about our specific population, the babies? And what can we do for them in their developing or immature brain to really optimize care and outcomes? So almost exactly 15 years ago, under the leadership of David Rowich, Donna Ferrero, Sam Hawgood, and others at UCSF, the Neuro-Intensive Care Nursery was initially established within our larger intensive care nursery. And I'll go through the details on the next few slides. But we refer to this as the Neuro-Intensive Care Nursery, or simply the NICN. And this is a virtual unit within our large nursery. So it doesn't officially have its own designated space, but includes babies throughout the nursery. It involves a number of different services including neonatology, child neurology, neuroradiology, developmental care, high-risk infant follow-up, and nursing and other ancillary staff. And so besides including champions or representatives from each of these disciplines, it's closely embedded with how we provide nursing and developmental care in our nursery. And for context, we now have approximately 68 dedicated NICU nurses who receive special training to take care of these brain-focused babies, over 20 of which are cross-trained with ECMO. And I do want to mention that this also ties into the clinical research that I'm going to talk about later, the clinical research that we do in our nursery. So this includes imaging and interventional trials at UCSF. But this model enables quick identification for those at risk. So not only to protect their brain, but who qualifies for enrollment or who can benefit from an investigative therapy. So our mission with this model is really to provide brain-focused care for all neonates with the goal of improving neurodevelopmental outcomes. So we do this in an interdisciplinary, with an interdisciplinary team approach or model. The idea that each of these services that I mentioned has an equal voice in the treatment and care of these babies. So just to provide more context, there's a dedicated NICN team that's staffed, that's on service for our nursery, aside from the neonatology team. So this is staffed by a child neurologist, as well as a child neurology fellow or neurology resident, and sometimes medical students. And so they co-manage the patients with diagnosed or suspected brain injury. They co-manage with our neonatology team. And I'll talk in a little bit more detail in the next slide about how that works. But once again, the point is recognizing that essentially all neonates that are critically ill in our intensive care nursery, they're at risk for poor neurodevelopmental outcome because the severity of their illness can impact their brain development. And so now we use this co-management model, as well as our various tools and devices, to really monitor and image the brain in the best way we can to understand what's happening to our patients, and then linking these models of care to our long-term follow-up programs. So when I talk about, neonates with diagnosed or suspected brain injury, that's a spectrum of disease and diagnoses. And like I said, there's quite a variety of different patients in our unit who are at risk for brain injury. And so this is basically demonstrates how we break down those babies when it comes to evaluation by our dedicated NICN team. So first, and I apologize, it's a little small, so I'm going to go through in a little bit of detail. So first are the Class A patients. So these are the ones that get immediate evaluation 24 hours a day, 7 days a week, either in person or by phone by the NICN team. So that includes babies with seizures or suspected seizures, neonatal encephalopathy, concern for hypoxic ischemic injury, inborn errors of metabolism, intracranial hemorrhage, ischemic stroke, suspected CNS infection. So once again, this is 24-hour coverage. Then we have the Class B patients. These are the more subacute patients. This is where the NICN team provides consultation and follow-up during daytime weekday hours, including those with malformations or dysmorphisms, hypotonia that's not otherwise specified, or an imaging abnormality that does not require an acute intervention. Now, the NICN team also consults for babies that receive an EEG screening for any reason. So, for example, a term kid with apnea and we're ruling out seizures, or there's something that doesn't quite make sense, we'll get an EEG and we'll get the NICN team involved. In addition, we also now routinely obtain an MRI prior to discharge in all babies that are born less than 28 weeks gestation. And so we consult the NICN team during their hospitalization, and then following imaging, the NICN team will discuss findings with the family and help determine plans for follow-up or if additional services are necessary post-discharge. Now, to provide a little more context, here's a breakdown of the reason for NICN consults in our nursery since creating the NICN team. You can see quite a bit for seizures and encephalopathy. And I think in the last 15 years, we've cooled, I'm going to talk about cooling in a couple of slides. We've cooled over 600 babies and I think evaluated over 2,000 infants with NICN consults. So our NICN leadership team, which once again has representatives from a number of different specialties. And so working together, the leadership team has developed guidelines and protocols to assist with both the acute care and initial management of these babies, and then chronic care as well. This includes various cooling protocols, which I'm going to discuss next, initial management of babies with seizures or suspected seizures, management of a number of other diagnoses that we see, including stroke, myelomeningocele, interventricular hemorrhage in premature infants, and post-hemorrhagic hydrocephalus, and surgical management of that. And really the goal with these protocols is providing earlier intervention when necessary, standardizing the care that we provide, and then preventing secondary injury. And so this includes protocol. Like I said, we have a number of different tools and things that we use as part of our neurologically based care. So protocolizing in who and how we monitor the brain with an EEG, who we perform brain imaging for, so MRI or head ultrasound, and how that and when to do that in preterm and full-term infants, and also how we transition those babies to home. So I do want to provide a little bit of additional background on some of the more common causes of brain injury that we see in our nursery and our strategies regarding management and treatment for those. Starting first with the two most common causes of full-term brain injury, which are hypoxic ischemic encephalopathy, or HIE, and stroke. So hypoxic ischemic encephalopathy, HIE, is the most common. It has an incidence as high as 6 in every 1,000 live births in high resource settings. And this often, there's patterns of injury that result from global reduction of blood flow and oxygen delivery. And I'm going to go a little more detail on the next slide. But importantly, this cause of brain injury is far more common and has a greater impact in low and middle income countries. So I'm going to return to that towards the end. Stroke is the second most common, but it's still very common, 1 in every 2,000 live births, which is similar to the incidence seen in adult stroke. This causes a more focal injury pattern, shown here on MRI as well. And an important point is, so this is a focal injury and it's associated with reperfusion injury. So we most commonly see arterial ischemic stroke. It's greater than 80% of strokes in newborns. And what happens is a thrombus is thrown and it obstructs the MCA or some other large artery. So there's an ischemia period, and then that clot is removed, it breaks down, and there's a reperfusion, so restoration of blood flow. But reperfusion is actually an important part of injury progression, and it leads to a lot of damage in the surrounding tissue due to secondary energy failure. So once again, those are the two most common causes of full-term brain injury, HIE and stroke. So talking a little bit more about HIE, because it's relevant when I'm talking about later, there are a few patterns of injury that we often see on MRI. And so this is how we subdivide it. It's not quite as simple as this, but for the sake of this discussion, I'm going to go through this. So term babies often exhibit vulnerability in the basal ganglia or deep gray nuclei, as well as the cortical and subcortical watershed regions. So term infants, they often suffer hypoxia or ischemia in a relatively limited time frame around delivery, as opposed to premature infants that can have repeated insults over weeks to months. And so I'm going to distinguish that injury pattern that we see on MRI. So we classically think about exposure to more chronic, low-level degree of hypoxia in utero, resulting in this cortical watershed pattern of injury. So for example, a mom that presents with a few days of reduced fetal movement. So maybe there's something going on for a longer period of time. And these are the regions between the major perfusing arteries that are more at risk. The outcomes in these infants is generally thought to be better than those who have a more acute and profound or complete occlusion of blood flow for a certain amount of time. That results in injury to the deep gray matter. There's a very high metabolic demand here. And so when you have, like I said, a complete occlusion or obstruction of blood flow, for example, if there's a uterine rupture or placental abruption or something where blood flow isn't going for a certain amount of time, these areas are at risk, and it results in more severe deficits. Now, there's a spectrum, and we often see kids with both, and so I'm going to come back to that later, but this is just for this, these are the most common things that we see. So having established that those are the most common causes of full-term brain injury, how do we identify those babies early on? Usually before we have imaging that provides a diagnosis. And why is that early identification so important? So we need to do this expeditiously so we can monitor and treat seizures when they happen, but really identify infants who may benefit from different neuroprotective or neuroparative strategies. And so I'm going to acknowledge this again. So HIE is the most common, but there's many potential causes of an abnormal exam or early brain injury. And so how do we accurately identify these infants with brain injury? So we and others use several criteria to identify these infants, starting first with the presence of neonatal encephalopathy. So neonatal encephalopathy simply means an abnormal neurological exam in a newborn that's consistent with possible early brain injury. So people often use modification of the Sarnak criteria, which are shown here, which it's basically a score of the level of consciousness, tone, reflexes, autonomic function, and respiratory status, to determine the degree of neurological abnormality. The history is also very important. So not just for a possible cause of this hypoxic ischemic event, but determining the timing of injury, because timing is very critical, and I'm going to get to that. Biochemical or laboratory criteria, such as cord gases or an early baby gas that indicate a possible hit to the brain. And then potentially early brain monitoring, like an EEG. Background activity on EEG is actually very helpful, but we often don't have that information. Like imaging, we don't have that information by the time we have to make certain decisions. So once again, why is that early identification so important? Why can't we just get an MRI a few days in and then move on from there? An important point is that even if there's a single specific cause of perinatal brain injury, like I said, a placental abruption or something else, injury continues to progress and evolve by several different mechanisms over a really prolonged period of time after an acute insult. And this is what we hope to alter with early therapies. And what I mean by early therapies, I mean specifically therapeutic hypothermia or cooling. Therapeutic hypothermia is the only proven clinical treatment that we have for these babies right now. And it's standard of care for these term newborns with concern for hypoxic ischemic injury, but it has to be initiated early by 6 hours of age. So there's a significant amount of preclinical and clinical evidence that's demonstrated that cooling, either dedicated head cooling or total body cooling, are effective in reducing the combined outcomes of death or moderate to severe neurodevelopmental disability if it's initiated early, once again by 6 hours of age, but also the earlier you initiate it, the better the outcome. And so these are our specific cooling eligibility criteria at UCSF. So babies have to be term or near term. These are our resuscitation and metabolic criteria. So a prolonged resuscitation or early acidosis, so to identify those who may have taken a potential hit to the brain. And all of these babies that are cooled have to have evidence of encephalopathy, or once again, an abnormal neurological exam. There's 6 listed here, which I mentioned before. So 3 out of the 6 have to be abnormal for the baby to qualify for the cooling. Now, important point is that what I just showed on the previous slide from there have been a number of large-scale cooling trials. So they enrolled babies with moderate to severe encephalopathy, so a little more significant neuroexam abnormalities. And they did that intentionally to adequately power the trials to prove the efficacy of the intervention, which in this case was cooling. But there's plenty of emerging evidence that those who present with more mild encephalopathy, meaning 1 or 2 abnormalities on the SARNet exam instead of 3 or more, those kids are also at risk for brain injury. About a quarter of them will have seizures or evidence of injury on MRI. And so they're also at risk for poor neurodevelopmental outcomes. And so I'm going to return to that at the end, since that's the biggest controversy in neonatal neurocritical care right now. Should we be cooling these babies with more mild encephalopathy? This is, I'll go through this quickly, but this is specifically how we do the cooling. We do whole body cooling, servo regulated using rectal thermometer, where they're placed on a cooling blanket through which there's cold circulating water. And they're cooled to 33.5 degrees Celsius, which is 92 degrees Fahrenheit, for a full 72 hours, after which they're slowly rewarmed. We do continuous video EEG monitoring throughout cooling and rewarming because there's a significant risk of seizures, which I'm going to come back to. Most of the babies are discharged between 7 and 15 days of life, which obviously depends on the severity of injury. And they get an MRI after rewarming. I don't know if I mentioned that. So another important point is that a number of our cooled babies are actually born at outside hospitals and transferred in. So during transport, we perform active cooling using a Ticotherm device, which is also servo regulated using a cooling blanket. So importantly, it gets these patients to the target temperature sooner and more stably during transport, because as I mentioned, we have a 6-hour window to start cooling, but really the earlier you do it, the more effective it is. Okay, so I mentioned we have to make a quick decision by 6 hours, but preferably earlier, on whether we should be cooling a baby. We don't have imaging. So how well are we doing? Are we cooling too many babies? Are we cooling not enough babies? How accurate are we at identifying them? So Marie Corley-Cornett is one of our neonatology faculty, and she's K-funded. She's studying HIE with Yvonne Wu in the Department of Neurology, also in collaboration with Kaiser and their very large database. And so here she looks specifically at the impact of prenatal maternal SSRI exposure on postnatal neurological exam and on outcomes. Now, for background, anecdotally, we've noted that neonates that are born to mothers on SSRIs, there's a slightly increased risk of having an abnormal neuroexam, also needing a prolonged resuscitation and needing respiratory support. And so because of what I just mentioned, abnormal neuro exam, prolonged resuscitation, they may have a borderline blood gas. Some of them get cooled because they qualify for cooling. Now, Marie wanted to examine this in a more systematic way. So she looked specifically at degree and timing of SSRI exposure and effect on outcomes. And she found that those with later SSRI exposure above a certain threshold or dose, that those neonates born to those moms are at significantly increased risk of having a prolonged resuscitation and an abnormal neuro exam, and actually qualify for cooling and are being cooled. Now, this is a diagnosis of exclusion. We don't want to miss babies who could benefit from cooling. So even when we know that they're exposed to SSRIs and acknowledge that that may be part of what we're seeing, we don't want to miss anybody. But this is just using this example of saying why it's so difficult to identify these babies accurately in such a short time frame. And so I'm going to pivot slightly to discussing other treatment that we provide to these full-term neonates with early brain injury just beyond cooling. So these babies, as I mentioned, are also significant risk for seizures. And it's not just HIE babies, it's these other things that I was talking about: stroke, hemorrhage, infection. Now, in newborns with seizures, approximately 70 to 80% of them have what we refer to as acute symptomatic seizures. So this results from things like I just mentioned. So some kind of acute process happening to the brain, as opposed to an inborn error of metabolism or a neonatal onset epilepsy. And seizures are associated with a poor outcome. So we do want to treat seizures to reduce the risk of excitotoxicity and those other injury mechanisms that be causing that injury to progress. So how do we approach this important issue of identifying and treating seizures? We do it through comprehensive monitoring and treating as quickly as we can. So when a baby's born and gets admitted to our nursery with encephalopathy or concern for brain injury or concern for seizures, the bedside NICU nurse rapidly applies amplitude integrated EEG leads on admission. So this is basically just an EEG, but just a few leads, more focused, that's shown on a monitor at the bedside that the nurses and the neonatologist can interpret. It's not as effective as full montage EEG, but it can be placed quickly. So it provides a screening for the bedside team while the EEG tech then comes to place the full montage video EEG, which is the gold standard. So here, because of the investment of our leadership and the focus on this neurologically based intensive care, we have 24-hour EEG tech coverage to place the leads and to troubleshoot problems. We also have 24-hour neurophysiology coverage. That's an epileptologist that's available to read the EEG when there's concern for seizures or new admissions or whatever else is going on. So another important point, because before we treat these seizures, we need to know what we're treating. One thing that's clear is that as a group, we're not very good at knowing which babies are seizing clinically. Many babies have what we call subclinical seizures. So they're seizing on EEG monitoring, but they don't have a clinical correlate. So they don't have repetitive movements that are commonly associated with seizures. And so that's why this consistent electrophysiological monitoring is so important. So in this study that was in Ireland, what they did was they used video clips of suspicious seizure activity, determine the accuracy of different providers in correctly identifying seizures. And so they showed these 20 videos of suspicious activity to neurologists, neonatologists, and neonatal nurses. The upshot is that the seizures were only correctly identified in 50% of cases. So it was basically a coin flip. Also, it didn't matter if it was a child neurologist, a neonatologist, or a nurse. No one group was better than any other in accurately diagnosing seizures based on the clinical picture. And so this was in babies that were having suspicious movements. And at UCSF, we see this as well. By providing continuous monitoring, we know which babies are actually seizing. Another important point is other babies are doing suspicious movements that we think are seizures but don't actually represent seizures. So these are paroxysmal events or myoclonic jerks. And so if we're not monitoring them, we don't know what actually represents underlying seizure activity. And once again, many babies have subclinical seizures. So seizures on EEG without a clinical correlate. And that's why this continuing monitoring is so important. So diagnosing seizures is one thing, but then we have to treat them. And so our goal is really to obtain the best treatment strategy for these neonates. So using our monitoring to rapidly and accurately identify those that are seizing, to get the anti-seizure medications into them as soon as we can so they can stop seizing. If it's not working, to reload or add another medication. But also just as importantly, to quickly discontinue the medications if the seizures have resolved. So I mentioned that the majority of neonatal seizures that we see are acute symptomatic seizures. So this type or this etiology of seizures, sometimes they can be very difficult to control for 2, 3, 4 days, but these are also the type of seizures that are most likely to resolve early on. And so we do want to treat them while they're ongoing, but by monitoring, we know when the seizures have resolved and we can take them off those medications, meaning a number of these babies can go home without these medications. And so that's fantastic. We have these protocols to identify and treat seizures, but is it really affecting outcomes? And so this publication by Sharon Wheatstock, she's a child neurologist both here at Mission Bay and at Benioff Oakland. She found that continuous monitoring, as opposed to just spot EEG checks or simply monitoring clinically, it resulted in a lower seizure burden and a reduced length of stay with this model of care. And the babies were also treated less frequently with anti-seizure medications and less likely to go home with anti-seizure medications. So as an aside, over the 15 years of having a NICN at UCSF, it also significantly increased the number of babies for which we care that were transferred from outside hospitals, specifically to monitor and treat seizures. So some babies have intractable seizures. Like I said, that could be a neonatal onset epilepsy or a genetic or inborn error, where you need continuous monitoring and expertise to determine the best treatment strategy. Okay, so one last point I want to make in regards to seizure management. It's not just diagnosing the seizures and ordering an anti-seizure medication. You need to get it into patients as quickly as you can. The sooner, the better. And so Katie Kramer is a neonatologist here, and she's our QI lead. And she helps lead a multidisciplinary team that includes pharmacy and nursing to work on quick administration of medications using a bedside seizure button that's pressed as soon as the decision to treat a seizure has been made. And so through this QI project and the use of this bedside seizure button, she was able to decrease the time to treatment almost in half through the combination of the use of the seizure rescue button, which is at each bedside in our nursery, as well as an education initiative. Okay, so now I'm going to transition to talking about premature brain injury. So understanding that these are also very high-risk infants, where what happens to them while they're hospitalized and while their brain is developing has a profound impact on long-term outcomes, and why neuroprotective care is so important. So the images up here on the left are of a preemie at 25 weeks, an MRI, and the same infant at term-corrected age, where you can see there's a significant increase in complexity basically throughout the entire period of hospitalization. And so this is a period of very rapid development. So much can happen while they're hospitalized that can impact the brain. So here, for example, there's arrows showing the development of multiple foci of white matter injury. So we think of premature infants as being highly susceptible to white matter injury. So basically a demyelinating injury, often in the paraventricular regions shown here. And Sonia Bonifacio, when she was here, she showed that even the exposure of a preemie to a line infection with staph epi, so something that, you know, where a baby wasn't particularly sick and in the scheme of things seems relatively benign, it can adversely impact white matter development and long-term outcomes. And so on this topic of preemies in brain-focused care, this is where preemie neuroprotective care bundles and IVH reduction initiatives are so important. So we continue to focus, as we focus on taking care of the rest of the baby and all the things we need to do for a critically ill premature neonate, that we don't forget about the brain. So importantly, having care bundles aimed at preventing acquired brain injury has been shown to reduce interventricular hemorrhage, which is something premature infants are high risk for, as well as white matter injury. And so this is more work from Katie Kramer and Liz Rogers and many others. So being consistent in our wraparound care that's ostensibly focused on a number of other organ systems, including betamethasone to reduce surfactant deficiency, indomethacin for patent ductus arteriosus, early skin care, early feeds, prioritizing breast milk feeds. All these have an impact on growth and development. But once again, it allows us to focus on how these impact the brain and long-term neurodevelopment. So what this table shows is reduction in IVH through these different interventions, as well as the opening of the Grove, which is our small baby unit, and also a reduction in mortality using these care bundles. So now I want to talk about emerging research at UCSF, but I do want to make a point first. So at the top of this discussion, I subdivided the topics really into 4 core concepts. And to this point, I primarily talked about identification and protection. And now I'm going to talk more about repair and optimizing outcomes. But the reality is all of these are interrelated and each affects the other. And we often refer to bench to bedside research. But as we all know, what we do clinically and our curiosity about what's happening to our patients, it frequently leads back to the lab and the questions we ask and the other investigative areas to inform what we do. And so, like I said, this is an opportunity to discuss some of the great work that's happening at UCSF. And so first, I'm going to focus on prenatal risk factors that affect early brain development and outcomes. And so Samita Jain is a new, has just joined the faculty. She recently graduated from fellowship. And she's working with her mentor, Xianhua Piao, on understanding the impact of inflammatory stimuli and maternal immune activation during pregnancy on brain development. And so she found that infants that were born to mothers with diagnoses suggestive of maternal immune activation, they are at increased risk of having neurologic morbidities during the first year of life. It also increases the risk of preterm birth, but importantly, prematurity and maternal immune activation were independent risk factors for neurologic morbidity. So suggesting that activation of a pregnant mom's immune system may disrupt the developing fetal brain and alter neurodevelopment. However, the actual cellular and molecular mechanisms that drive this are still not well understood. And so another difficulty in this research is trying to answer questions about what's happening in the human brain. It's challenging because of limited access to developing human fetal brain tissue. And also there's a limited ability of animal models to recapitulate this complexity. And so Samita is using neuroimmune organoids. So this is basically a novel human stem cell-based 3D culture model. And she's using this to understand the impact of immune activation on embryonic and fetal brain development. So related, Melody Lunn is a 4th-year neonatology fellow, and she's also a PSDP recipient. And she's working with her mentors, Michael Wilson and Sam Pleasure in neurology, to examine the impact of autoimmunity during pregnancy on later outcomes, including things like autism spectrum disorder. And so to examine the impact of autoimmunity on brain development, she's utilizing techniques that were pioneered in her mentor's lab, specifically FIP-seq, which is immunoprecipitation sequencing to identify and understand autoantigen generation. And so using this technology on CSF that was obtained from children with autism spectrum disorder, Melody has identified a number of enriched antigenic targets, with plans to further study these novel targets back in the lab. Now I'm going to move slightly forward to premature brain injury following delivery. So Dawn Gano is a child neurologist here. And so she, in collaboration with Donna Ferrero, Jim Barkovich, and many others, she examined the development of the premature brain by comparing scans like scans I showed before, comparing scans that were obtained earlier in the hospitalization for premature infants, and then again at term gestation or at the time of discharge. And a very interesting and relevant finding was the high incidence of cerebellar hemorrhage in this population, which prior to this was not as well recognized or understood. So importantly, cerebellar hemorrhage is associated with slower hindbrain growth, and it affects neurodevelopmental outcomes. So the next question is, why is this happening to premature infants? So Mark Peterson is a neonatologist here and newly R01 funded. And so he's examining this mechanism and risk factors associated with cerebellar hemorrhage in preemies. So specifically the role of inflammation on fibrinogen deposition and how that impacts neurogenesis, as well as cerebellar growth. But once premature brain injury has occurred, is there anything we can do to repair it? So currently in the nursery, for premature infants, we provide supportive brain protective care using those bundles that I mentioned. We treat seizures and other conditions as appropriate, but there are no specific therapeutic strategies to repair the premature brain after injury. But that's something Bridget Ostrom is looking to change. So she's a child neurologist here. And so she, in collaboration with others, is looking at potential therapeutic options to change that. So as I mentioned, premature infants appear to be most at risk for white matter injury. So this is defective myelination for a number of different reasons, which obviously has a profound impact on long-term outcomes. So she, with collaborators Jonah Chan and Ari Green, are using a drug screen. So basically a scoring system using currently approved FDA medications and then using that in an in vitro model of myelination to find potential treatment strategies for white matter injury. So they found that the antihistamine clemastine can rescue hypomyelination, and it has shown promising results in preclinical small animal models of early brain injury. And so soon they'll be conducting a phase 1 trial. So this is called the RAP trial, to examine clemastine use in premature neonates with diagnosed white matter injury, diagnosed by either head ultrasound or MRI. Since we're on this topic of how our clinical experience, I'm going to go to term briefly, but we're on this topic of how our clinical experience drives our research endeavors. I want to bring this back to full-term infants and really how we can work to identify effective strategies for low resource settings. So as I mentioned, HAE is more common and more devastating in low and middle income countries. And as I also mentioned previously, therapeutic hypothermia or cooling is standard of care in high resource settings. But in low and middle income countries, it was unknown how effective it was and how feasible it was. And so what I'm showing here is the outcomes of the HELIX trial. So this was a phase 3 trial, a very large trial, which examined the efficacy of cooling in low and middle income countries. Now, disappointingly, cooling did not work. It was actually harmful in this setting. It increased mortality with a number needed to harm of 9, and there was a lack of neuroprotection. So, as a result, we need to work on finding other therapeutic options or strategies for low resource settings. And so this is where effective modeling of brain injury is so important. I talked about this at Grand Rounds a little over a year ago, so I'm not going to go into too much detail, but I want to mention the work of Emin Maltepe and many others. So in collaboration with the Gates Foundation. So basically what they've done is set up a modeling pipeline where potential therapies that can be used in low and middle income countries can be studied in a systematic way to determine efficacy and dosing prior to human trials. And so Emin shared this slide with me, and these are examples of potential neurotherapeutic options that may be feasible in low resource settings. The ones in green are the ones that they've tested or are undergoing testing. So Emin uses an ovine or sheep model, and there are many people involved in this, but I want to call out specifically Yana Mike, who's faculty in Peds Critical Care and recently KO8 funded, and Yasmin White, who also underwent specific pharmacology training to help out with this, and she's a recent graduate of her neonatology fellowship program. I want to mention one more thing related to the basic science work and the importance of our integration with clinical care before I transition back to how this is impacting our clinical management. So at UCSF, there's a brain bank. It's overseen by Eric Huang in neuropathology, and it has specimens with a number of different diagnoses: HIE, stroke, premature brain injury. And these can be used to further understand what's happening in humans, which, as I mentioned, is different than even the large animal models. And so Betsy Crouch's lab work utilizes these samples to understand neurovascular development during gestation. And I'm not going to go through that here because she presented that relatively recently. But I do want to mention that she, in collaboration with many others, has worked to develop relationships with families of terminal patients to encourage them to consent to autopsy and use brain tissue for research so we can study and better understand what's happening to their child and many others. And so she has a funded study, and this was actually just published last week, that's really focused on determining how we can better partner with families and how they can be part of the research mission here at UCSF. Once again, to understand and hopefully eventually repair the brain. It just demonstrates the importance of partnering with parents and other community advocates for the research that we do. So I do want to discuss one other cause of brain injury that we see relatively commonly in our nursery that I haven't brought up. And that's in the patients with congenital cardiac disease. So once again, we know prematurity is a risk factor for brain injury and hypoxic ischemic events perinatally. That's a cause of brain injury. And as I mentioned before, preemies are more a risk for white matter injury, often paraventricular white matter injury, whereas full-term infants are often subdivided into those who have deep gray injury or cortical watershed injury. Like I said, for the sake of discussion, it's easier to process when they're subdivided. The reality is it's more of a spectrum. So Patrick McQuillan and Stephen Miller and others have shown that full-term newborns with congenital cardiac disease, specifically transposition of the great artery and single ventricle physiology, those kids, we know those kids were at risk for stroke. because of their underlying physiology and need for balloon atrial septostomy or to go on bypass for surgical repair. But interestingly, when you follow these kids chronically with imaging, those with the single ventricle physiology or transposition, they often have developmental brain injury, specifically white matter injury. It's a little hard to see here. That's very similar to what we classically think as premature brain injury. So the brains of these kids are exposed to longstanding hypoxemia in utero due to their underlying cardiac physiology. And this may be responsible for this finding in full-term neonates that we thought of as more classically associated with premature infants. And so Shab Pavandi is a pediatric cardiologist here. She previously showed that this white matter injury in these cardiac kids predicts motor outcomes at 2.5 years of age. And so now Shab is the PI for a currently enrolling trial called the Transit CHD trial to better understand what's happening here. What's happening after they're born? What does their postnatal cerebral oxygenation look like in babies with transposition of the great arteries? And are any of our interventions impacting this? And I also want to mention a separate study. So, when I talk about cardiac kids, I'm talking about full-term infants right now, but we take care of quite a few babies with quite a few premature infants with congenital cardiac disease. That's something Dr. Reddy, people send babies here so Dr. Reddy can operate on them when they're very small and very tiny. So we have quite a few premature infants with congenital cardiac disease. So how does being born early for these kids with these conditions impact their brain development? And so Patrick McQuillan and Lauren Harasimu, she's one of our neonatology fellows and recently PSDP awarded. They're examining the impact of preoperative care or early surgical intervention on this specific population, the preemie population, and how our postnatal care and our postnatal care goals, oxygen saturation, blood pressure, how that affects white matter injury and brain development. So I do want to end by discussing social determinants of health and how the hospital and post-hospital course affects outcomes. So by post-hospital, I mean specifically the transition to home and follow-up care, and the reality that structural racism leads to different health outcomes. So I've talked about these different neuroprotective care practices and bundles. The reality is that they are inequitably practiced here and everywhere. And so we as providers, as educators, as researchers, as administrators, we need to figure out how to fix this. And so here's an important and related point. So I've mentioned MRI quite a bit in this talk. We generally consider MRI as the closest to the gold standard for diagnosis and the best early prognostic indicator of outcome. But it isn't as simple as that. So meaning there's a lot of things that can happen between, for example, day 4 MRI and school age that affects outcomes. So in a cohort of 500 cool babies that were followed until 2 to 3 years of age as part of the HEAL trial, those with more severe injury patterns at MRI were far more likely to die or have neurodevelopmental impairment, which isn't surprising. But the interesting finding was that those with mild or moderate brain injury on MRI, they often had similar outcomes to those with normal MRIs. Meaning for that some of these kids with brain injury, we don't know what they're going to look like a few years from now. And so Stephen Miller's he's now the chair of pediatrics at Vancouver, and he and his colleagues have published excellent studies on the importance of the home environment for premature infants that are discharged home with MRI findings of brain injury. So it's what he and others refer to as the importance of the everyday. So the bottom line is that the home environment is one of the biggest and possibly the biggest predictor of long-term neurodevelopmental outcome. And so they've used different measures of socioeconomic status, such as level of maternal education. And the bottom line is those at the highest SES, those kids have the best outcomes despite MRI findings. So if they had moderate or mild findings, they often had very good outcomes, where some of those with lower SES with mild or no MRI findings had worse outcomes. So I'm simplifying to some degree, but the point is we as a group, we don't know why that is. We don't know what that secret sauce is. Why does that matter so much? And there's a number of possible answers, but the bottom line is we need to understand what we can do to bridge that gap to provide the best outcomes for all of these babies. And so this was a study by Kayla Carvinen. She's a neonatology fellow here in collaboration with the Preterm Birth Initiative, where she examined structural racism in our nursery and outcomes after babies were discharged. And so she presented this at Grand Rounds a couple months ago, but I just want to call out one thing. this great study that she did focused on Black families. And this was for the state of California. So basically Black families from the lowest quartile based on a scoring system for racial and income segregation. So those in the lowest quartile were far more likely to have, after discharge, frequent acute care visits, readmissions, and death. Once again, this was after discharge. So that's why not just the hospital course, but really that transition to home is so important. This is a very big determinant of long-term outcomes. And so acknowledging that, how do we reduce this inequity? How do we improve outcomes? And so this is from a publication out of Boston, really aimed at understanding the inequities and offering guidance to identify interventions and delineate mechanistic pathways to really potentially eliminate these inequities in long-term neurodevelopmental outcomes through research, intervention, advocacy. And so we need to, we need to figure out, in the nursery, how to optimize building those relationships with families in the community during the hospitalization, providing adequate education and support before they go home, and then optimizing that transition to home and post-discharge follow-up, including our follow-up systems, how we schedule appointments, access to those, transportation, understanding the importance of those, and doing that in a way that makes sense for more families. Because the reality isn't, once again, that they're being discharged at home, but they're really transitioning to a new environment where they still need support and care. And so this is something that a statewide collaborative as part of the CPQCC, which is statewide quality initiative. So this is called, and it's called NeoBrain. It aims to do to promote neuroprotective care practices for very low birth weight infants, but through the lens of equity inclusion. And the UCSF California Preterm Birth Initiative is utilizing research, community partnerships, and education to create positive change for Black and Brown families. But we still have quite a ways to go. Since I have a couple minutes, I do want to end by briefly mentioning one controversy that I mentioned before that we're collaborating with others to try to address. So, as I mentioned, those with mild encephalopathy who don't qualify for cooling at some places, depending on the cooling criteria, they're still at risk for poor neurodevelopmental outcomes. So this is a publication from Yi Li. She's a neuroradiologist here, examining outcomes in babies with mild encephalopathy. So as I mentioned, those with mild encephalopathy often have patterns of brain injury and MRI that are similar to the patterns that we see in those with more moderate or severe encephalopathy. Once again, some places cool these babies and some don't, but the efficacy of cooling in this population is not known. Now, it seems low risk to cool them. We've done a lot of cooling. We think of it as relatively safe. So if there's a potential benefit, why wouldn't we just cool them? And for transparency, we used to cool anybody with any SARNet abnormality. Oakland does not. And as part of integrating our care across sites, we sort of met in the middle. But it's true, we don't know if cooling will benefit them. But then you ask, why don't we just cool them? Well, their exam findings may be more mild because it was more remote injury. Like I used an example before for cortical watershed pattern of injury, where a mom may have decreased fetal movement for a few days and then come in. Likely that injury started at least a day or days before. And I mentioned how important it is to start cooling within 6 hours. So these kids may be outside the cooling window. So there may be no benefit to cooling them. Also, it's not a benign thing to admit a baby, take them away from the parents, cool them for 3 days, limit their feeds, and sedate them to keep them cool if it's not going to benefit them. So to help answer that question, there's now a multi-center study, Lena Schulich in Dallas is the PI for this, where we will compare cooled and non-cooled infants with mild encephalopathy and determine your 2-year outcomes. So Natalie Chan is a neonatologist here, and she's also the director of our follow-up clinic, and she's serving as the site PI for this trial. Okay, a few final comments. So the next frontier of neonatal neurocritical care is using our monitoring and imaging modalities and new technology that comes, and figure out ways to interpret that wealth of data that we receive using computational bioinformatics and other mechanisms to really provide more individualized evaluation and care to understand who can benefit from these different therapies. And that's the promise of precision medicine. So having said that, protocol-driven care and consistent approaches to brain protective care, it improves outcomes. And this needs to be provided not just in one unit, for example, not just in our nursery, but any unit in the hospital that takes care of infants that are at risk for brain injury. And we need to continue to use our expertise to educate outside providers, provide support, but also determine when a baby needs to be transferred or an intervention needs to start, and doing that in an efficient and effective way. Continuing to emphasize the research mission for bench to bedside research and back, and partnering with parents and members of the community to equitably enroll patients in clinical trials. And an important part of our mission here is training and developing the next generation of brain-focused providers. So we have a neonatal neurology fellowship that was recently accredited thanks to Hannah Glass, and this is funded through philanthropy. Nursing education and support are critical, and not just here, but to nurses and providers in the community. And once again, not really focusing on discharge to home, but transition to home. And continuing to be curious about what's happening to these newborns. Why is it happening? Which allows us to frame questions and then work to find solutions in the lab and other places that will improve outcomes. Okay, so there's way too many people to thank, some of which I mentioned by name in this talk. But I do want to end by thanking all the providers, and more importantly, all the patients and their families that have made the NICN special. So thank you.
Thanks so much, Fernando. I'm happy I got to be here. I had to run to a code and come back. So
oh wow,
yeah. You guys didn't even miss me while I was gone. Naomi's giving you a party hat confetti thing, I think. So so I'm going to open this up for questions. I did have a question, but I can hold it for others to go first. And you feel free to unmute yourself.
I have several questions. So,
okay.
Fantastic presentation,
Thank
and
you.
I'm amazed by everybody and your work. So I have. Do you try first for the treatment of seizures? Do you try pyridoxine? There was a paper that was published in '99 when we didn't have the cooling yet as a treatment of HIE, and that was from patients in England. That said that about 30% of patients with newborn patients with HIE were responding to pyridoxine, and they did have at least a third of them to had genetic genetic causes for this pyridoxine deficiency. That's one. The other is, are any other convulsions given intranasally as an established routine treatment, or do you use any intranasal nanoparticle anticonvulsants, for treatment and or for your research kind of preventatives for HIE or anything else in neurological diseases in the newborns, but I am not sure that is used even in the adults. Then you mentioned something about activation of maternal immune status, and I was wondering if you would routinely check mothers with a kind of arthritis, lupus, and or systemic sclerosis, which, or even with joint pains, some mothers are diagnosed because of the babies, because of that. The other is in the low-income countries with HIE infants, did you notice any difference between females and males? Because I know from the ROP studies, the babies who had severe ROPs, the newborn preterm babies with severe ROPs, that was more frequent in males than females. And when I asked in India, some of the professors in ophthalmology, they told me that was because of social reasons, and that was because the female preterm babies with severe European blindness were not kept alive, so they didn't make it to the statistics.
Mhm.
And
Okay,
there
let's have Fernando start answering some questions, and then maybe we'll be able to get to another question. as
sorry.
well.
I'm
No,
sorry.
thank
Okay.
you, thank you.
I answer this as efficiently. This is a practice of my efficiency. So paradoxically, so when we're worried about a genetic epilepsy, then we don't routinely, most of these are acute symptomatic, but if we're worried about some other cause, then that's something we'll consider. But we don't use it as frequently as we do, but that is something we think about. Second is intranasal administration, only to treat a seizure if we can't get IV access, but we don't prioritize. We always give IV medications, but if there's some reason there's no access, then we'll consider intranasal. You talked about sex differences. I don't know, you mentioned low resource. I didn't know if you meant for the Helix trial or just in general. Most of the cooling trials actually didn't report sex. For the HEAL trial, which is 500 babies, we did, and there was no sex-based difference. Specific to the Helix trial, I'd have to go back and read. I don't recall if they reported that. Hopefully that answered in a very quick way most of your questions. Yeah.
Fernando, my question was actually harkening back 20 so years when Stephen Miller was a fellow here with me, showing my age. Stephen, actually, I think he won the Grumbeck Award. I recall he giving grand rounds, and he actually showed in the BAMRI data that parental income was associated with outcome. And I think the cutoff was somewhere around 100 or 150K 20 years ago in San Francisco, right? But I think it was somewhere around there. And Larry Shapiro, who was their chair at the time, said, "So should we just give everyone money?" I think he was kind of joking, but anyway, I just wanted to get your thoughts. Is this, what do you think is affecting? So you go from having these, equivalent MRIs to having, more, you're identifying this vulnerable population based on the socioeconomic status. And what do you think? Should we just give everyone money? No, I'm just kidding. But what do you think is affecting this?
Yeah, that's an excellent question. The short answer is I don't really know. I mean, we can be hand wavy about it and say it's access to resources. So, they need PT, OT follow-up in these things consistently, access to care, going to the appointments in a scheduled way, advocating for your children, but a lot of it is probably rolled around just what the home environment is like. So if you don't have, where if it's an environment where both parents work or they work nights, and so they're not interacting as much with the child, somebody's taking care of the child, but like just being there with the child, just talking in the room, as we know, just even having conversation in the room or reading to the child really helps language development. And so, like I said, we can kind of say it's a little bit of all of those things, but like I said, it's a little bit hand wavy. That's why I see it was Stephen. I took that from Stephen. It's like, we don't know what the secret sauce is exactly. He was the one who said that, so I stole it. But I don't know. I imagine it's all of the above, but it's complicated, right?
Yeah, for sure. Are there any additional questions or any additional thoughts from anyone? We're at the hour.
Yes, we should give everybody money. The question is where to get it from. Bill Gates.
Yeah.
Elon Musk.
Okay.
Okay. Well, thank you so much, Fernando. Thanks everyone for joining us.